If we look at overall at the epidemiology of COVID, and I was checking with the WHO material from around the world, and what we're seeing is that the reported numbers continue to be in the decline. I'll see if I can do a screen share again, just to quickly show you the total, the outbreak curve. And you've got it on your screens. It should be in the bottom left-hand corner. The numbers of cases are the colored bars which are merged together. The numbers of deaths are the black lines. And this is an arithmetic scale. And you can see it gives you the 2020 picture and then what's happened in 2021. And there's this extraordinary phenomenon of the cumulative reported case numbers during 2021 have been declining quite nicely. This is driven mostly because of a decline in the reported case numbers in the USA and in Western Europe. In the figure that you can see, the shaded yellow is the Americas and the shaded green is Europe. And that's where the numbers just have dropped remarkably. And going country by country, we see in most European countries, the numbers are dropping as well as in the US. However, if you look at the disaggregated data on the right-hand side here, the Brazil numbers are still pretty high. And France, although it's not very clear, but if you can see my cursor, the France numbers are holding high as well. And I'm going to dive into France in the next few minutes. And in Europe, the figures of the Czechia, Czech Republic, they staying quite high as well. Okay, so I'm going to dive into those. What I mentioned last week was that I was hearing about hotspots of severe illness and death in different parts of Africa. That continues. And I want to talk a little bit about the Africa picture before we move on to the second half of my report, which is going to be about vaccines. So, first of all, why is there this really rather lovely drop in cumulative numbers of reported COVID cases throughout the world since the beginning of the year? Answer, in my view, this is because of increasingly widespread practice of non-pharmaceutical interventions by people. The summary are always physical distancing, mask wearing, surface cough hygiene, and self-isolation when sick, accompanied by protection of those who are most at risk. The second reason for this is that governments are once again imposing widespread movement restrictions, and in some cases referred to lockdowns. And we've got the UK in quite a stringent lockdown at the moment, France with a curfew, and various patterns of movement restriction, particularly in Europe, as well as in many other parts of the world. And all the evidence is that that does reduce transmission, but we've always said in these briefings that it also is associated with major social and economic consequences. So going into UK specifically, really quite a lot of rejoicing in the country that there's been this reduction from 30,000 new cases reported per day to currently somewhere in around the 9,000 mark. And I thought that, I want everybody to really appreciate what an incredible achievement the UK results are. But, and there's always a but with COVID, but with the numbers coming down, movement likely to restart because of obviously both economic and political pressure for lockdown release. We've now got a date from the UK government for schools to reopen and a staged programme of lockdown release that's been announced since we last spoke. It is inevitable that numbers will go up again. And the advisors to the UK Prime Minister have been very, very clear, whether they are the formal advisors like Chris Whitty and Patrick Vallance, or the informal advisors who get quoted a lot in the newspapers. everybody is saying numbers will go up. And I think it's inevitable that where countries have used movement restrictions as their primary means of controlling spread of the virus, that once you release movement, which you must do, then the case numbers go up again. How much more disease are governments prepared to tolerate? Well, here there's very interesting new equation emerging, that if a country is using vaccination as part of its strategy for pandemic management, what happens? Well, we're already seeing in the UK that the use of vaccination is almost certainly leading to a reduction in mortality rates. And that's what you would expect. Targeted vaccination of people in older age groups should lead to lower deaths, lower hospitalizations. And I think that that really is what's happening in the UK. 25+% vaccinated. Of course, there'll be some throughput to the actual sickness and mortality experience of members of the population. Great, that's good news. There's also some hypothetical data on the extent to which this quite high vaccination cover is going to actually impact on virus transmission. And I think most people feel that the early evidence suggests that actually virus transmission is being reduced through vaccination. All good. However, this general situation at the moment is really fragile in the UK. As I said, there will be an upsurge once movement really restarts. What form of upsurge that will be is open to question. So where can we get clues? Answer, I think we have to look at France. I was listening last night with Florence to a report from the French Prime Minister, Castex, describing what's happening in France and the strategy being used in France. The French are trying not to use lockdown, but curfew instead to slow the spread. But they are very worried about what's happening in 3 regions: Dunkirk in the north, Moselle, which is a bit eastwards, and then Nice in the south. In all 3 of those areas, there are spikes and then surges building up. Now, that's what we have with COVID. It's not like flu where you get it in big waves and they're a bit seasonal. With COVID, it's constant transmission and it comes in localized spikes. And then these localized spikes, if there are spreading events or there's an institution that is responsible for a lot of transmission, those localized spikes turn into surges. So there's a surge underway in Dunkirk, seems to be associated with the so-called UK variant. There's a surge underway in the Nice area, seems to have been associated with a really high level of population movement about 6 weeks ago. And there's the surge in the Moselle area, which seems to be associated with quite a lot of cross-border movement between France and neighboring countries, Belgium and Germany. I think it's important to recognize that this is going to be the pattern for the foreseeable future. As movements sort of build up in different places, we will get spikes, we will get surges. And what French government is doing is localized movement restriction and very intense work with where these surges are occurring to interrupt transmission through case detection and isolation. And that has to be accompanied with genome sequencing if you're looking for variants. I think that the approach being taken by the French government is exactly what we would have recommended as part of our whole work on COVID-ready societies last year. You've got the virus still there as a threat. You can't go for zero COVID. This has been ruled out by the French government, but you can go for really quite rapid isolation of the specific area where the surge is occurring. It's not easy, it's politically quite difficult, but what was interesting when trying to pick up what was happening in these 3 different areas of raised infection rate in France was that there seems to have been quite careful work between Paris and the locally elected parliamentarians, the local authorities and so on, and really quite a high measure of agreement that a rapid and extreme movement restriction in these areas where the spikes were occurring is the right way to move forward, because, as we've always said, if you get the infection early and you have a rapid and robust containment operation, you stop the spread to the rest of the country and you actually get a more rapid return of economic activity. So much so that there are parts of France right now where the local authorities are saying to central government, can we have a short period of movement restriction at a high efficacy, in order perhaps that we can get a more rapid return of economic activity, which again is part of the COVID-ready thinking, that you get the local actors saying to central government, actually, we do want to do this, we want to do this together. So everybody, I think continued focus on non-pharmaceutical interventions with a really more sophisticated testing regime so that you can pick up where you're getting your spikes and surges building up. The use of genome sequencing to see whether or not you've got a variant coming, and as in brackets, as we keep saying, variants will keep coming more and more, and then the ability to restrict movement in a local area, deal with the outbreaks, particularly through isolation with cooperation between local authorities and central authorities. That is really what COVID ready means for the time being. So we've got spikes in the UK. John sent me this morning a report of something happening in Rutland, where there's a spike that seems to be associated with quite high COVID transmission in an institution in the Rutland area. Exactly what we'd expect. Just like last year, we were seeing spikes building up in areas linked to transmission in meat plants, or transmissions in detention centres, or transmission associated with a ship docking or something like that. That's what can spark a spike. And in particular now, we often, when we see a spike, we think, variant, and wonder whether or not that's because of a variant emerging. It's almost, they're happening so quickly now that it's almost impossible to keep up with the variants. So that, I think, is going to be the pattern for the foreseeable future. Spikes and surges picked up, often perhaps picked up through a sort of a sudden emergence of deaths, cemeteries full or bodies piling up, plus, of course, build up in number of people coming into hospital. So I thought I'd just spend a moment or two just looking at some of the reports we're getting from hospitals around the world, because that's, it really is often a newspaper report that tells you something's going on. So Brazil, okay? We've already talked about Manaus in Brazil, where there was a variant together with high levels of infection, oxygen ran out, it was Amazonas, really totally devastating situation. But here we go to another part of Brazil, state of Sao Paulo, and then again another part of Brazil, the city of Porto Alegre, reporting very high numbers of COVID cases coming into intensive care units. Sao Paulo has got its highest level of hospitalization since the beginning of the pandemic, and high bed occupancy together with numbers of severe cases. And then you get that sort of notion of health system collapse. Well, health systems don't sort of collapse in a total way, but what happens is people turn up, try to get into hospital, end up lying in hospital corridors or not getting treatment, or even, as we found sometimes in the African situation, not being able even to get in the door. It's very distressing. Health workers overstretched and so on. This will go on happening with the spike and surge phenomenon, and it seems to be continuing to happen in Brazil, and I'll come back to that in a second. So Sao Paulo did what I would have said was absolutely the right thing, implemented movement restrictions on the 22nd of February to try to reduce COVID-19 infection rates and the pressure on the hospitals. And then in part of Sao Paulo, they went further than movement restrictions. They imposed a lockdown in order to try to really stop the virus from spreading. And then they found this, that was a local variant, what they call the P1 variant, which seems to be particularly responsible. And so that's what it is. You'll get the spikes and the surges. Local authorities will find their hospitals are overwhelmed. There will be really serious issues for health workers with really just unfortunately being stressed out. And in some cases, as we've heard from different parts of the world, they'll die. And you have to have really firm local action. You have to stop movement out of these areas because you want to stop the variant spreading into the rest of the state. Why is it so bad in Brazil? Well, it's back, why are there certain countries where it just seems that COVID is just going on and on and on? UK, US, Brazil, Mexico. Answer, these are the countries where there was not an early, rapid and robust response when the virus first appeared. And the virus is just everywhere. And even if you use lockdowns to try to contain spread, to get your numbers to drop, remember, the virus doesn't disappear with a lockdown. It gets frozen in place I think that to go back to what we said last year, it's not a bad idea here. So you can see the consistency. But with a lockdown, the virus is locked in place. But if you had one of these gradual early responses to COVID, there is a lot of virus in your community. And that means that inevitably you're going to go on getting spikes and surges until you really push the numbers of cases down, 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 down. I think there's a chance that the UK will come through after the present spike drops and we get right down to very, very low numbers of cases. Won't get down to zero COVID, but get down to low numbers of cases. Then as the lockdown is released in the UK, schools go back on March the 8th, there is a chance that the numbers will stay down, but it does require absolute vigilance. The testing, tracing, treating, isolating, often derided as a non-functional scheme in many European countries. But it has to be there. That's the basics of public health response, and we mustn't forget it. So I looked at the lockdown release plans in the UK. I thought, where is the test, trace, treat, isolate scheme? Why isn't it being sort of really, really pushed? And the answer is it's not there. And I think there's a bit of politics here. I think that the emphasis on the UK lockdown release is the stages of getting pubs restarted, sports games with spectators back again, a sort of political agenda. And because the test, trace, isolate scheme in the UK has just been derided continuously and the people running it have been pilloried, almost certainly that's politically not a cool thing to mention. But I'm actually quite interested to see that behind the scenes, there's been a lot of work to try to get that test, trace, isolate capacity localized. How else was the Rutland surge discovered? And use that as the basis for moving forward. So there will be spikes and surges. They will have to be picked up and managed through test, trace, treat, isolate. When it gets really bad, as in Sao Paulo or in these 3 zones in France, then there will have to be localized movement restrictions. There may have to be firm lockdown if it gets really bad. Then you take the pressure off health services, you stop the variant from spreading, and things get better. I wanted to just talk a little bit about vaccines, and just only because it's so interesting what's going on. Big news last week, not this last week, was that the first COVAX vaccines went out to Ghana, and then 2 days later, I think it's to Côte d'Ivoire. And that is just remarkable. I got interviewed during last week, and the questioner said, "Isn't COVAX really slow?" I said, "Absolutely not." And let me spend 5 minutes explaining why I think COVAX is fit for purpose and why I really want strong support for it. Firstly, COVAX is a bulk purchasing scheme that offers all who want access to vaccines at negotiated prices with an effort to establish a fair and, frankly, totally transparent allocation scheme, because there's a vaccine shortage, so there's an effort to try to make sure that those who need the vaccines the most and who are ready to use it get the vaccines first. Second point, COVAX uses vaccines that have been given an emergency use license by the World Health Organization and are produced in manufacturing plants that have got a good manufacturing practice certificate. And that's super important. With a vaccine, it's the vaccine itself that matters, as well as the circumstances under which it's manufactured. 3 vaccines have received emergency use licensing from the WHO. One is Pfizer-BioNTech mRNA vaccine. The second is Moderna mRNA vaccine. And the third is the AstraZeneca-Oxford vaccine, which is a more traditional vaccine structure. The AstraZeneca-Oxford vaccine is currently being manufactured in at least 3 plants around the world through a licensing procedure. The 2 key ones that the WHO is interested in are the Serum Institute of India manufacturing and the SK Pharma in South Korea manufacturing of the Oxford AstraZeneca vaccine. So it was necessary to get a good manufacturing practice certificate from these 2 plants, the SK Pharma plant in South Korea and the Serum Institute of India plant, as well as having the emergency use license for the vaccine. The combination of licensing and approvals came through about 10 days ago. It's a very rigorous process. It takes longer for the WHO to approve than for a national authority to approve, because the WHO approval is for the world and not just for one specific country. And within days of the approval, the vaccine has been distributed first, as I said, to Ghana, second to Côte d'Ivoire. This is pretty remarkable. And even in the advanced projections of COVAX, it was never intended the vaccine would go out around the world till the first quarter of 2021. So I'm pleased about that. I'm also pleased that COVAX, together with WHO, have done a lot of work to make sure that countries are ready to do vaccination. And there are obviously one state of readiness for the supercold vaccines, like the mRNA vaccines. There's another state of readiness for Oxford AstraZeneca. There have been various reports of people saying that they have preferences between different vaccines, but all that I've read suggests that Oxford AstraZeneca is a super good tool, and it's absolutely great that there is now widespread manufacturing building up. There are a number of vaccines that are now being used around the world that have not yet been through the WHO emergency use licensing and good manufacturing practice procedure. WHO people are clear to me. You know, a country has the right to use whatever vaccine it likes. And if they choose to use one before it's received WHO authorization, that's the national decision. And we need to be clear on that. Now, various vaccines are still going through their authorization process. There's a big vaccine production tracker spreadsheet on the WHO website. Enables you to look at, I think, something like 180 vaccines that are in preparation. You can see where they are in terms of their preparation. You can actually get details of what's going on in terms of negotiations with the manufacturers on getting the various bits of licensing through. Plus, there's some quite useful material that I discovered on relationships between WHO and the manufacturers. Also, I've got some useful material on what WHO's view is on perhaps countries going to get vaccines not through the COVAX process, perhaps to try to beat the queue. And it's quite clear that that's perfectly possible for a country to do, but it can be quite expensive for the country because they often have to pay more if they go for direct negotiation rather than use the COVAX advanced purchase agreement. And you can see the problem. A country may say, we've got to have vaccine in order to be able to vaccinate our population. That's a political imperative. And they then get frustrated that they have to wait in line for the COVAX system to work. Whereas if they go direct, they can get it quicker. And that's happening everywhere. I mean, there are ministers of health who are having to resign. There are presidents whose future is in doubt because there is a buildup of public pressure to access vaccines. That in turn means there's political pressure to bypass the COVAX system. But of course, the more countries that bypass the COVAX system, the more difficult it is for manufacturers to fulfill their agreements they've got with COVAX at reduced price, and that in turn destabilize the COVAX process. So it's a delicate situation, and Tedros, the Director General of WHO, has to walk a kind of fine line in saying, come on, it makes economic and public health sense to take this scarce commodity, a vaccine against COVID-19, and give it to the world's health workers and others who are at high risk first, and not have it all sucked up in the vaccination for rich countries. But as we've discussed in several previous sessions here, that's real politics, that's what's actually happening, and we just have to live with that reality, even though it's causing quite a lot of upset and angst in different parts of the world. And I still hope that we will move to a point where the politicians in wealthy nations will realize that in the end, a good political decision is one that actually focuses on what's right for the world rather than what appears to be right for the short-term interests of a country. And that especially applies to the UK, which is becoming global Britain and which really honestly will lead friends around the world in the coming weeks and months. And I'm quite glad to see that in public debates in the UK, the notion of vaccine equity or enabling everybody to access vaccines is rising higher up the political ladder. Thank you very much indeed for the chance to share these words. And I'm now going back to Twee, half time. If you wouldn't mind taking us into that. And please, if you'd like to speak, please let us know, ideally through sending a message. And Catherine Deland is tracking everything that comes in through the chat and is sharing with me. Sarah McFarland, if you feel like talking, please do let us know. It'd be lovely to hear what you're up to these days and also your take on what's happening. Okay, could we go to Twee, please?
Thank you, David. Now, while the team pulls together all of your questions so we can respond, here is a little bit of a poll for session 8 of series 3. So the first question is our public health question. So what is an example of a public health measure that has a large-scale impact on dental health? Fluoridation of water, toothpaste discounts, or sugar tax? Question 2 is SAGE has issued 3 sets of interim recommendations to date. Now, these are the 3 that David mentioned earlier. The Pfizer-BioNTech vaccine, the Moderna vaccine, and the AstraZeneca Oxford vaccine. So what does SAGE stand for? The Strategic Advisory Group of Experts on Immunisation, Senior Advisors Group on Evaluators on Immunisation, or Scientific Assessment Group on Evidence for Immunisations. Question 3, and this is the more fun one. I like to keep a bit of a thread from one briefing to another. So you may recall last week, Claire Rayner, who was our long COVID expert as well, was sharing with us the importance of keeping healthy. So this question is related to that. What have you found most difficult to keep up with over the past year? My thought is, depending on what you respond, I'll bring together some answers and tips and tricks for you next week. So while the responses come through, I'm just going to spotlight our illustration from Chris Shipton and open the floor to you, Chris, if you'd like to make a comment on what you've drawn so far.
Oh, hello.
Hello.
Yeah, apologies for national stereotyping again. And I think, like, you know, I live in Oxford, so there are actually people at the school gates here who've been working on the vaccine. And I think, you know, what I'm hearing is that people are worried about the sort of potential health risks of schools reopening on the March of 8th, but despite their medical knowledge, can't wait. It cannot happen soon enough. But there we are.
Oh, yeah.
Can I just say, Chris, I mean, you say stereotyping and so on with your John Bull, like that, but this is wonderful.
Thank you.
Oh, thank you so much. Thank you so much. Everybody, I'd like to actually have 2 themes to the conversation today.
Oh, mute alert.
Thank you. I'm going to go back to Twee.
Oh, so I'll just share some results with you and then we'll back to you, David. So answer to question 1, 80% of you did get it right. It is the fluoridation of water, and it shows you the impact of when public health measures are put in place, there can be a big impact. On question 2, It is the first answer. So almost half of you got this one right. Is it's the Strategic Advisory Group of Experts on Immunisation. That is 15 members of it. They are in the group in their personal capacity. And then there are 10 working groups on different topics, including HIV, influenza, and of course, COVID-19. And they play an important role that feeds into the emergency use listing of WHO. And then for number 3, exercise is the most difficult to keep up. So I'll be back next week with some tips on keeping up your exercise during the pandemic. Thank you. Over to you, David.
Twee, it's remarkable to be working with you and the fact that you've managed to keep us all going. Yes, mine was exercise in what's toughest one, and I'm glad that you're going to give us some tips. I look forward to that. Very good. 3 areas that I'd love to hear your reactions if you feel like it. The first is it'd be really great to continue to discuss patterns of disease. If you're connecting from anywhere around the world and you're seeing things that surprise you in terms of full hospitals or reports of clusters of severe disease or death, we really like to know about that. Often what you tell us here, it really builds our understanding of what's happening. And remember, I keep talking about localized spikes and surges. So that means that actually they may happen in an area with a diameter of only a few kilometers. Secondly, the response, technical issues, particularly stories about vaccine rollouts, particularly surprising vaccine rollouts. We like to hear about them. We try not to make comments on vaccine rollout decisions that could be taken and misquoted. It's a very, very delicate time, particularly for people who have status, the international organization, to be talking about that. Thirdly, I want to talk about moving forward, forms of civil organization, governance, international arrangements, what seems to be promising. I keep telling you that in due course, I believe world leaders will find a way to work together on COVID. I think national political leaders will find a way to work together. Though I must say I keep being surprised by what I see happening, the fact that it still seems to be desirable for people to bicker rather than to work together, but that's, I think, still a temporary phenomenon. On that third one of the route ahead, I'd really like to ask John Atkinson, Holly Wheeler, and others to comment. I think Karen Kaplan might comment as well, so I want to leave time for that. On the more information about what's happening around the world, I note that Jane Badham might be able to tell us a little bit about a very interesting phenomenon of the Johnson & Johnson vaccine rollout in South Africa. Why is the Johnson & Johnson vaccine so relevant there? And Iman was going to say something perhaps about what she's seeing in Sudan. So, but Annie Feltham, please, would you mind just starting with your comments, as always, on the UK and what you see happening? Annie, over to you.
Thanks, David. Hi, everybody. I think we really need the vaccines to work here, because we still fail to attack the systemic issues. This where we started right in at the beginning of these sessions last year. The inequity and the poverty issues, they are so hardwired into how we manage our society that changing them, there doesn't appear to be the political will for it. And I think we now have our roadmap, and it's whether people will just maintain, I think, the high level of compliance around social mixing, which is just really hard. So as usual, I've got positive and negatives. Thanks, David.
Annie, I think that's great. I noticed that consistently you do see the plus minus, you navigate some of the paradoxes. Thank you very much indeed for sharing. I just want to say, Chime, if you would like to come in at all, please signal on the chat. For me, it would be really nice to hear from you about what's happening in your neck of the woods. I'd also be really pleased to, just looking, I couldn't work out whether, Karen, you're prepared to speak or not. So I will come to you, but if you're going to sleep, then just don't answer. Thank you very much indeed. Chris Langton, just to say, haven't seen you for a few days. So if you want to come in a bit when we invite John, Holly, Karen to speak, you're welcome. And everybody else, just get our attention, get our eye. Now, so Jane Badham, please. What are you seeing in South Africa?
Yes, hi David and hi everyone. Great to be with you again. Very exciting is with South Africa, with the beginning of the rollout after our AstraZeneca arrival, and then working out that it actually didn't have the kind of impact on the new variant, which we're very definitely avoiding calling the South African variant, because it actually is no longer all over South Africa. And I think that's another thing, David, that we really need to avoid stigmatizing the variants to a country. So we're very clearly trying to avoid that. The interesting thing is that the rollout now is of the J&J vaccine. And because that vaccine isn't yet registered, it's very cleverly been done that the rollout to our frontline health workers is happening as part of a clinical study instead. And that has, I just put down a couple of really good benefits of that. The first benefit is, because it's part of a clinical study, the rollout is actually being controlled by the researchers. And that does deal with some of the other potential issues that we could have with rollout, and we were expecting with rollout from the political level. The second thing is that it really has, I was on a webinar last night with the researchers, Prof. Penny Moore and Glenda Gray. It really has been shown to have incredible efficacy on the new variant, which is great. Thirdly, the benefit is it appears at this point to be one dose, but of course we were discussing the fact that it's probably going to get like the flu vaccine, where you will probably need to have other doses as the variants change. I think also excitingly was the temperature control is not, I think it's -20, I stand to be corrected, but it's a lot easier to control, and even at fridge temperature can be kept for a period of time. And the next is that it's also really boosting the research, because some 45,000 health workers have been receiving it, and they now are in essence part of a clinical trial. And then finally, the last thing I wanted to say was, I think they've also been very clever in how they are allocating the vaccine, and that they've got what they call a 70-30 ratio. So 70% of these vaccines are going to the public sector frontline health workers, but there is a recognition of 30% going to the private sector, but all the vaccines being administered through the public sector. So private healthcare workers at the front line are having to go to those public sector hospitals to have the vaccine. And I think altogether what it's done, and I wrote in the comment boxes, I've certainly in the last week felt a much greater feel of people feeling more positive about it, even though the rollout to the rest of the population is going to take time. But it certainly has given a big boost. And I think also it's dealing with the skepticism that existed before we had it. So those are just my messages on South Africa. Thank you for the opportunity, David.
Jane, that's beautiful. And I think all of us, certainly me included, are feeling a huge lift because these vaccines are coming on stream. They've come on stream quick. The cooperation to produce them is amazing. COVAX as a construct is very exciting, but also the kind of special things that are being done, like the South Africa approach. And just to say, Jane, two things on your remarks. One, everybody does not want variants to be named after the place where they have been characterized. yet it's almost impossible to avoid. I was discussing with the people at WHO on variant nomenclature. The alternative is numbers, and those don't just hold on when you are in the media and so on. So although I agree with you, it's really awful using South Africa variant or Brazil variant 1 or UK variant. I'm afraid it's pretty hard to stop. Secondly, this applied research as vaccines roll out is super important. When we were dealing with Ebola in West Africa in 2014, 2015, we had an experimental vaccine, and it was used as part of the containment effort using ring vaccination. Goodness me, it was effective and very inspiring for everybody who was just struggling, thinking how we're going to get this Ebola managed. And now, of course, the same vaccine is being used for the resurgence of Ebola in West Africa. I love your description of how it's being done. It's a beautiful vignette. Thank you, Jane.
And David, just the last thing is really just to say that issue, I think what's been really clever, and I think it was unintentional, was actually the fact that the initial rollout is being done by researchers and not necessarily by the government. I think that's actually doing a trust building in vaccine. And I think that's an unintended but positive consequence.
I think it's beautiful. Hold it. Beautiful. Thank you. Sarah McFarlane, thank you for joining us. I saw you've lit up your vid. Do you mind just telling us what you're up to? We haven't spoken for a super long time.
It's great to be part of the group, David. I'm glad to be back in the UK. I've been in the States for a long time, so back in Liverpool. And I'm following all this with great interest. One question I heard was being discussed in the States yesterday by Zeke Emanuel was why COVAX decided to give vaccines to Ghana rather than, for example, Peru, and where there's such a high intensity. So I realize there are really good answers to that, but I'd be interested in yours.
I don't know the answer, Sarah, but there's something to hold on to. I have not been able to get information about the choice of the early recipients of the COVAX vaccines. So I have to just pass on that one. On my screen above you is Vicky Doyle, who you might either know or remember as part of that group that we work with Dave Hammond.
Hi, Vicky.
Thank you very much for coming. Could we go to, I'd like to invite Holly Wheeler, then Karen Kaplan, then John Atkinson, just on thinking through how we'll come through this with either local stories or global stories. Holly, please.
Morning all, lovely to see you. I guess the things that I'm noticing at the moment is how challenging it is for leaders to keep their attention both on their immediate response of how to do vaccine rollout, how to make sure the hospitals can still accept people, to respond to community need. So in some places here that just the food poverty is enormous. That attention and dealing with that and thinking about the longer term impact around things like the inequality, the likelihood of job losses and high levels of unemployment, the changing nature of the kind of way in which we live. So missing things from high street interaction, so the way that we actually talk to each other, and the fact that it's so difficult now to get the same level of intelligence about what's going on in your population because you can't talk to people aren't interacting in the same way. And to hold both of those things at the same time, I can see that some leaders are really trying their best. So in the UK, we have things called health and wellbeing boards and trying to develop new strategies for the health and wellbeing board. So doing a longer term view is definitely something that I'm starting to see political leaders starting to engage with at a local level, but not at a national level. I think the thing that I'm experiencing at a national level is much more of an attention on restructuring, moving functions around, as opposed to thinking about what functions are for. So I'm hoping that we can have a different conversation about that as we go forward. And the metaphor that I've been playing with is around whole system shock. So when your body goes into shock, I'm sure most of you know much more about this than I do, but the process of withdrawing and centralizing things into your heart and lungs, and the immediate problem is the thing that gets the most attention and energy. But actually, if you don't start to solve the other problems, then you're going to get effectively loss of limbs and other functions. And so I can see some of that centralization process going on in our human system, where we're drawing things into the center and trying to control them from that point of view. I can also see some other things where we're not paying attention to the data and information in the kind of outstretched bits of our system, because we haven't got the connectivity going on anymore. So I think I'm trying to find new metaphors to help people think about the short term and the long term together. So that's where I am at the moment.
Thank you very much indeed. Hold that. Contracted or shriveled societies, which are being perhaps just not understood by political leaders. And thank you for telling us about the metaphors you're looking to. I'm going to get Karen Kaplan, then changing the order, want to bring in Mihir Butt, and then John Atkinson. So Karen Kaplan, please.
Hi, nice to see you all. It's in the middle of the night for me, so I'm going to spare you my disheveled appearance. Okay, quick things. In New York, or just, the US overall, I'm feeling a lot less fatalistic than I was a few weeks ago. We're on track. The more vaccines we'll get into arms, it's working. I think we need to spend a lot more time than we are on racial equity, and making that the first, second, and third thing we talk about every day in terms of access. But I feel like all these things are in motion, and I'm feeling quite positive about it. I'm scared shitless about these variants, and being able to tamp down transmission, because we've had 2 nice days in a row and the streets and shops and restaurants were packed, jam-packed. And that's just a recipe for disaster right now. And everybody has spring fever. So we shall see what's happening, but at least all the systems are in place and we have a really fantastic team. But I am inspired by all the things that I see launching. I focus on Africa, but the Community Health Impact Coalition is launching this week with UNICEF and WHO for community health workers to get them vaccinated, and also the overall campaign to get them paid, largely female and unpaid community health workers on the last mile. So I like that campaign, and I love the campaign that the WHO launched with the EU and Global Citizen this week, the 5-point World Recovery Plan. I think that's really exciting. And also yesterday, the launch of the ACT Accelerator, Unit Aid, Wellcome Trust, the COVID-19 Oxygen Emergency Task Force in the first 20 countries and LMICs before it expands, globally to almost $2 billion. There's just a lot of really exciting stuff happening. I know I shared on the LinkedIn community last week about Shyvent. I think I did. I hope I did. My brain is mush at the moment. But there's this guy who's been shortlisted for the Royal Academy of Engineering's Africa Prize, and he's created a ventilator that can be used on the last mile. You don't need a specialized physician. It doesn't need electricity, and it uses much less oxygen.
Right.
And voila! I'm feeling inspired.
Good, and I think the COVID recovery plan that you just described, I think you've written about it in the chat, is super exciting. Thank you for sharing with us all these exciting developments for the last mile, as it's called. And they're going to be transformative. Great, great. Could we go to Mihir Bhatt, please? Welcome, welcome. Thank you for joining.
Well, thank you very much for inviting me, and I'm still learning from what all of you are doing. It's my great honor to be part of this group, and thanks to Loy and to Gued. Thank you very much for this opportunity to talk about some of the work that we are doing. This is in no way representing the work that's being done in India. It's a huge country and lots of experts. It is only from my window of the work that we have been doing. And one of the most important things recently we have found is related to the reopening of schools, and the demand there is coming that why teachers who every day meet large number of students are not considered frontline workers, and would it make sense to cover them beforehand so that not only they are protected, but the students are protected and the education itself is protected. And some calculations suggest that it is almost as good as protecting frontline workers who are health workers. So that's a discussion going on, a fair amount of fervor. So that's one thing I wanted to put for discussion. The second thing I wanted to put on discussion is the flow of funds related to this whole pandemic response, and a lot of demand at local level in terms of they having know what to do, having standard procedures, but not having resources necessarily to even make a small expenditure. And that's something, and I know it's not directly public health, but at the same time, without resources, performance is becoming very, very difficult. So that's the second part. The third is, it seems like an enigma to the reports about the spread of the pandemic in the tribal areas and communities of India. So is it really that there is some sort of resistance and they haven't been affected by that, or it is underreporting? And that's something, if anybody has any way of finding out more, that would be very, very useful. We have done several publications on impact of pandemic in India, South Asia, Southeast Asia, and also Asia Pacific and global. And I'll share that with Loy and to Guen with you, please. And if appropriate, they can be shared. And the last part is from the research community. There is a demand that relatively far more social science perspective on what is happening as far as the unrolling of vaccine is concerned is there than some of the public administration and public health related expertise. So social science perspective on far more on the rollout of vaccine. So these are the points I wanted to make today. Again, thank you very much. I have a bad connection, so I'm putting my video not on all the time. Thank you.
Thank you, sir. Everybody, Mihir Bhatt is leading the All India Disaster Mitigation Institute. And what's beautiful is that he and his team are looking at the kind of issues that constantly exercise us. I thank Loy Rego for bringing me here in, and I encourage everyone to, for example, look at this analysis that suggests that immunizing school teachers early on in the pandemic vaccine rollout might be a really very significant way of limiting spread, especially if you believe that schools are rather important amplifiers for virus movement in societies. Thank you very much, Mihir, for being with us. I am going to try to do something naughty. I'd love to hear from Chaim Shine, just to say a couple of words before we go to John to end this moment. Chaim, please. Where are you physically?
Yeah, so now I'm in Israel. I moved here. I moved over about a month ago, and I would like to say a few things. Number one, I don't know why I've not heard at least mentioned the IBM project WNTRAC. I wrote about it in the chat. It is a project that IBM set up. It says artificial intelligence assisted tracking of non-pharmaceutical interventions. So the IBM did a very big artificial intelligence project where they collect all the data of anything which is not directly pharmaceutical done in the world. And I think it's good to know there are many other ways to do things other than putting people at home. And all the ideas are there. They collect data from 6,000 websites and from many other places. So I think it's worth looking at it. The other thing I wanted to say is that in Israel, I met people from the Israeli Red Cross. They are in charge of all the vaccination program and the testing program. They have an amazing system, and it's an NGO. So basically, for cost price, they're ready to give it. They gave it already to, I'm not sure, one country in Africa got it. And it's very good system. It gives all the data, all the messages to the phone, registering everything, collecting the data. So if anybody wants, I can connect to them. And another thing which I wanted to say is about ventilators and about oxygen. So I understand there is a lack of oxygen and also a lack of ventilators. In South Africa, they started to use a product from Israel as well, which has got a long time battery system, and they have a lot of stock availability. Actually, we talked to them yesterday, and with them as well, we can connect directly to get it from the countries if anybody wants. And about oxygen, the same. There are oxygen generators that are available in places, and also there are plants that people can set up in countries which are available at the moment in the market. There is a Perry, it's a big company that you can get things from. And I just wanted to say, maybe we should arrange from time to time the people who know things that people can get system to use. Maybe it's good to share this information all the time, because all the time people are lacking things and lacking just technical things that we don't know how to find, and it's good to share this information. Thank you.
Chaim, I'm just saying to my colleague Catherine here, we need to connect with Chaim about the Global Respiratory Support Partnership that we've been involved in, ventilators, oxygen and systems. It'd be really great to get your advice. I thank you for making the point that one of the benefits of this kind of grouping is that we share. And remember, everybody, the morning sessions that we do are always less well attended than the afternoon sessions. Atkinson, please, just to give your thoughts and conclusions as we get on with the rest of Friday and the weekend.
I would just say, let's remember why we do things. We get caught up very easily in the what, and I think Holly said we have to say, what is this function for? So, quick example, in the UK, we got very excited about the number of tests available to us. And the people who run the tests are very pleased with their performance in terms of the number of tests that they can deliver. We have about a capacity for about 800,000 PCR tests. We're using less than half of it. So why do we do this? We do this because we want to break chains of transmission. And that's the thing that we need to be looking at in all this. Are the activities that we're doing delivering the purpose that we expected? And if so, that's great. But if not, why not? And I noticed Florence Egal put a little comment in. We need to look at the social as well as the technical. How are people using the things that we intend to do? And we need to learn. And so that example from South Africa, David, really, really important. Thank you.
And so that's what we do. We share, we learn, we ask questions, we evolve. For me, these sessions are just so enriching. And as I've told you before, this is how I get my ideas and my thoughts, both for my work as WHO Envoy and occasionally for my opportunities to connect with people through media. Thank you for your generosity. Let's stay connected. Twee, if you'd like to just close us out, that'd be great.
Thank you for joining us today. We will be back next week, 4 p.m. Central European time here. You can find the information on our website at 4sd.info. Thank you for joining us, and we'll see you again. Please connect with me on LinkedIn if you'd like to join our community chat, where we keep the chat going throughout the week. Thank you. Take care.
And let's just lighten up Chris's, thank you very much, everybody. Let's lighten up Chris's illustration, which will be posted on the website. Thank you very much, Chris. If you want to say anything last minute, we'd love to hear from you.
Yeah, it's always really great to be a part of this. All my illustrators that I work with found these talks are really kind of helpful to just understand what's going on. We don't work in public health, we work in other sectors, but we always bring a bit of this to the other areas we work in, and it's probably kept us sane throughout all of this. So it's always great to be here.
Please convey our real appreciation to the whole community with liveillustration.co.uk. Thanks, everybody.